Good evening, good afternoon, and good morning to everyone across the globe. And welcome to the 6th World Congress of Cochlear Implants in Emerging Nations and the 18th National Conference of the Cochlear Implant Group of India. We begin with the pre-conference World Cafes, a unique concept that was introduced first by Dr. Fatih Bhakti of Alexandria in Egypt at the 5th World Congress of CI in Emerging Nations under the aegis of the Global Cochlear Implant Access Network in Cairo in 2019. And this was a concept that was quite unique. And the objective of this exercise was to choose a focused area that has challenges, controversies, and this area of interest carries in terms of assessment, diagnosis, and management diverse opinions. So the experts in this field have been chosen, put together to come to some sort of consensus guidelines and recommendations. And we do 2 hours of, roughly 2 hours of deliberations. And the moderator is also handpicked, as in this case, it's Dr. Amit Kishore for this particular topic. The structure, we just put in a guideline saying for about the first 1 hour, you could share your experiences, either you speak about it or you share some slides and talk us through it. And in the next 1 hour, the moderator will have specific questions with a view to putting together the recommendations and guidelines. This compiled by the moderator would be presented as a summary, a short 12-minute summary on Sunday morning in the actual conference. And this summary would also be hopefully put together as a possible publication in a peer-reviewed journal. Without further ado, may I request Dr. Sumit Kumar Gaur, the treasurer of CGCon 2021, to introduce today's moderator.
Thank you very much, sir. Greetings to all. It's my pleasant task today evening to introduce the moderator for today's session, Dr. Amit Kishore. Dr. Amit Kishore is a senior consultant and professor in ENT, neurotology, and cochlear implants at Indraprastha Apollo Hospital, New Delhi. He's also the director and lead consultant of Adventist ENT and cochlear implant clinics, Delhi. He is a graduate of Armed Forces Medical College, Pune, and he obtained his higher surgical training in the UK and is a fellow of RCS Edinburgh and the RCPS Glasgow. He has received a number of awards and traveling fellowships. He was a consultant and senior lecturer at the Glasgow Royal Infirmary University Hospital before returning to India. With over 25 years of experience, he is the lead surgeon for cochlear implants and hearing implant program at Apollo Hospitals, Delhi. With a personal series of over 1,500 cochlear implants, the program is also one of the 2 in the country for auditory brainstem implants. His academic profile includes 6 book chapters, including the latest edition of Scott Brown, and over 30 articles in peer-reviewed journals and numerous presentations in national and international fora. He was the secretary of Cochlear Implant Group of India and is the co-founder and managing trustee of the I Can Hear Foundation. Over to you, sir.
Thank you very much for that introduction, Sumit. It's great to see you. I'd like to take the opportunity to thank Dr. Sunil, Dr. Medicary, and Sumit and Apoorv, the rest of the organizing, the core organizing team for this year's CGCon and the GCIN, and for this opportunity to run through and moderate this very interesting and challenging panel. So I would like to very quickly introduce all the panelists who are with us today. If I can ask Anil or Diksha to please bring that up. So our first panelist well, that's going to be hard for me to move. Yes, that's great. So Javier Gavilan, I've met Javier before, a wonderful gentleman. He's the head of otolaryngology in Madrid, La Paz University in Spain. He studied medicine in Madrid and completed his ENT residency at the La Paz Hospital, University Hospital. He was a specialist ENT surgeon at various hospitals in Madrid until he got the professor of ENT, the Faculty of Medicine in the Autonomous University of Madrid in 1989. He was then appointed head of otolaryngology service at La Paz University in 1997, both at the General and the Children's Hospital. And in 2005, qualified as professor of the specialty by election, obtaining 3 years later the position of professor of ENT at the University of Madrid. So welcome, Javier, to this panel. Great to have you. Next, please. Next is Dr. Rodriguez. Dr. Rodriguez has unfortunately fallen ill and has sent his apologies, but nevertheless, we will introduce him. He is a graduate from the State University of Campinas and did his medical residency in otolaryngology, a fellow in otologic and cochlear implant, and a Master of Science in otolaryngology at the UniCamp. He's the coordinator for otolaryngology in Sao Paulo and has experience in medicine, especially in otolaryngology, otology, and lateral skull base. I'm afraid he's not here with us today. He's recovering from illness. So next one, please. Right, Dr. Fatih Bhakti, as you heard from Dr. Sunil, who was the originator of the World Cafe concept, which is a great concept. Again, Dr. Fatih, we will have his video. He is a little busy, but has sent in an introductory video. He is currently the Emeritus Professor in ENT at Alexandria in Egypt, and has held previous positions of head of ENT department in Alexandria, head of otology in the Alexandria faculty, and was professor of ENT in the Alexandria faculty in Egypt. He's got multiple publications and presentations, books, and supervisor for numerous MS and MD theses, and is a reviewer of a number of journals. So that's about Dr. Fatih Bhakti. We'll hear his video in a short while. Next, please. We have Dr. Neelam Vaid from Pune in India, and Dr. Neelam Vaid is the head of the CI program and Big Ears, the audiology speech pathology department, KEIM Hospital in Pune, and she's a consultant in the Department of ENT at the same hospital. She's very actively involved in research, clinical treatment, and education in all aspects of ENT, and special interest in otology, neurotology, skull base, and sinus surgery. Numerous publications in national and international journals. She's on the editorial board of otology, neurotology, and on CI Internationals. She's an international recognized speaker, a wonderful speaker, and is involved in lots of national and international teaching programs, both in CI and endoscopic sinus. We welcome Neelam. Great to have you on board. Next one, please. Dr. Galal, we hope that his technical issues will be sorted soon. He's a consultant in otology, cochlear implant surgery at the Hearing Speech Institute in Cairo in Egypt, and founded and was a supervisor of the cochlear implant project at this institute, and was a former vice dean of the same institute. So welcome, Dr. Galal. Dr. Saad El-Zayad is again from Egypt. He's a professor of otolaryngology and consultant in the cochlear implant surgery and the implantable hearing aid program. His expertise is in surgery for hearing, vertigo, skull base, advanced ear surgery, and also snoring, endoscopic sinus laryngeal surgery, and treatment of tinnitus and hearing loss. So welcome, Dr. Saad. He sent in his video of his presentation and will join us soon, hopefully. Next, please. Dr. Madhuri Gore from Bengaluru in India. She is esteemed professor in audiology at the SRCI Institute of Speech and Hearing, with a lot of experience in audiology and in cochlear implants. Was trained in Sydney and at the Bionic Ear Institute in Melbourne. She's the founder member of SIGI and has served as the president of the Indian Speech and Hearing Association and the vice president of SIGI. Very active in teaching and in research and an active audiological clinician. So welcome, Dr. Madhuri Gore. Next, please. Dr. Naresh Panda is at the Department of Otolaryngology, a postgraduate institute at Chandigarh, and they have a lot of projects. He's a very academic gentleman and a very active program. His skills and expertise are in otology, head neck surgery, deafness, skull-based surgery, and other otological surgical procedures, numerous publications, and a lot of research projects under his belt. Dr. Panda, welcome. Thank you for being there. Next one, please. Dr. Ram Babu is a consultant in ENT at Apollo Health City in Hyderabad in India, an MBBS from Kunnu Medical College and Masters in ENT from Koti Hospital in Hyderabad. He served in the Indian Army for a short while before moving for a stint in the MOH Iran. He's a member of various institutes and a lot of associations. He's active surgeon in the cochlear implant surgical program in Hyderabad, which has over 2,000 cochlear implantees in the last 2 decades, and part of the team that saw the first state government program, CI program in the country. And we all are, all in India, very grateful to their team for having started this whole process of government-funded program. He also is part of an NGO called SAHI. They do a lot of work to aid hearing impaired for those who are needy. Welcome, Dr. Rambabu. Dr. Shankar Medikeri from Bengaluru is the director of the Medikeri ENT Center with a lot of work experience of over 40 years in ENT and implantation otology. He also has a lot of teaching experience for 2 decades at the Ramaya Medical College and the Sri Siddharth Medical College in Tumkur. He's the holder of gold medalist in ENT, has done very well and was first ranker in ENT in his MS. He's an FICS of the International College of Surgeons in Chicago and a fellow of the Royal College of Surgeons of Glasgow. He's been the past president of the AOI, Bangalore and Karnataka, and past president of the Cochlear Implant Group of India. Has delivered a number of guest lectures, both nationally and internationally, mentored numerous ENT surgeons, both in India and abroad in cochlear implant surgery. He's a technical member of the government-funded scheme for cochlear implantation and is also the chairman and on the coordination committee for the clinical trials of our Indian indigenous cochlear implant Shravan. Welcome, Dr. Medikeri. Wonderful. So with all these stalwarts, that will of course take a lot of time. As we have discussed, the format is that we are going to request each of our esteemed panelists to make a short presentation to share his or her experience and thoughts on this topic. The topic, as we know, what we're going to discuss today is this very debatable and challenging issue of the decision making in cochlear nerve hypoplasia or cochlear nerve deficiency. Do we opt for or counsel for a cochlear implant or a brainstem implant? What sort of decision making process? So at the end of this, we will try to come up with some sort of guidelines that we might have from our experience. So without further ado, I would like our panelists to start with their presentations, and we'll probably go in the order of the introduction. So Javier, you were introduced first, and we would like to hear your presentation first. At the end of the hour, we'll run through some questions. I've shared these questions with all of you, so you have an idea of what's coming. And the idea is just to summarize, for all of us to summarize what we would have talked about, so that I can put it all together and present it at the SIGI 3 days later. So Javier, right away, the screen is yours.
Thank you very much, Amit. Thank you very much, all of you, for being there and giving me the chance to share with you our experience on this, as Amit said, really challenging and exciting topic. The idea of what to do when the nerve, the eighth nerve, is not really there or may not be there. It's really a challenge, and this is one of my favorite topics nowadays. Before starting, I would like to thank Sunil and all the organizing committee of this conference for giving me the chance to be here. Here means Madrid. Right now it's 3 o'clock, 4 o'clock in the afternoon, but this is the only thing we have now, so we have to accept this, and I hope we can meet each other in person very, very soon. I would also like to thank my good friend, Dr. Luis La Saleta, who's working with me in this field for the last 25 years. Okay, to start with the problem, there are some situations where we can only use ABI. So those are the conventional indications for ABI. So these are the situations where ABI is the only option for hearing restoration. And even though I know we are going to deal just with kids, in adults, we have the NF2 cases when you remove the tumor and you have a nerve section. And in children, the situation is different because you can use ABI. You will have to use ABI, or ABI will be your only option when there is no cochlea, which is away from the topic of this discussion, or when there is no nerve or the nerve is not completely normal. So to go on with, to go on with this, the real problem comes in these situations where ABI may be an alternative to CI. So cochlear implant may be an option, but we are not sure whether this is going to work or not, and maybe we should go to an ABI. So deciding whether to go for one or the other is what we are going to deal with this afternoon. In adults, just to make it short, this is in patients with NF2, and these patients, you treat them, you remove the tumor, and you are able to preserve the nerve. For these patients, we have been actively participating in the development of the intracochlear test electrode. I think we will discuss about this further, but these patients may have ABI. If you preserve the nerve, they may have ABI or cochlear implants. Just to make this story short, in these patients, adults with NF2 surgically removed, and preservation of the cochlear nerve, the results with cochlear implants are much better in our experience than those with ABI. Of course, these cochlear implants are worse than conventional cochlear implant. But if a cochlear implant works, it must be accepted as the best option in this situation. Now let's move to the decision in children, which is the main topic today. In children, we have what I call the gray zone. If the children doesn't have a cochlea, well, there's no question, as I said before, but the gray zone includes, in my opinion, 3 different clinical situations. Number one is the one that we are dealing with today, which is bilateral cochlear nerve hypoplasia. Because if there's a plasia, even if there's a plasia, you can discuss this. We will have this in the discussion, because some nerve fibers may go with the 7th nerve, with the facial nerve. So even with aplasia, but with hypoplasia, you still don't have a real idea of what's going to happen with the cochlear implant and what can you get with an ABI. And there are 2 other situations that were not included in the title of this World Cafe, which are bilateral severe cochlear malformations. I mean, those malformations, when there is almost no cochlea, no cochlea, no way to put a real electrode that will give you a good result with a cochlear implant. And maybe in those cases, we have to start thinking about an ABI. And of course, also with massive bilateral cochlear ossification after obviously meningitis, which is the main cause for this. These patients in which you are not going to be able to insert more than 1, 2, 3 electrodes will probably be get benefit from an ABI. But these are away from the topic of this World Cafe, which is cochlear hypoplasia, cochlear nerve hypoplasia. And I will be very brief because we have only 5 minutes, and let you know that in our experience, the key factor is time. And what do I mean with time? Well, I mean that if you see the patient as we all want to see the patient, just after birth or very early during life, then you have time to put a CI, and if this fails, you can go for an ABI. In my practice, in our experience, in these cases, if there's hypoplasia, there's still the doubt of a nerve going there, you can use the test electrode. But in our practice, what we do is go for the CI. We try the CI first, and if the CI fails, as the situation is at the beginning of the process, we still have time to try an ABI. And this is the ideal situation, but the fact is that life is ideal only in movies. In reality, it's not ideal. And with these patients, it's very frequently non-ideal because these patients go from doctor to doctor, from place to place. No one decides what to do. And sometimes, and at least in our practice, in our clinic, sometimes you see them just at the end of the implanting window, this time frame where you are able to solve hearing by putting some kind of hearing device. So when time is over and you only have one bullet for that patient, we go for the ABI. Right now, we go for the ABI. Why? Because our results with ABI in children, unless what happened on NF2 adult patients, the results we have with ABI in children are very, I wouldn't say very good, are very, the idea we have is that they may be the future. They may give better solution than cochlear implant in those situations when if you fail, you will get nothing. So for these patients, we choose ABI. And we choose ABI, we can put the ABI through a translab approach. That is the one that we use with adults with NF2 because we are using the translab for the removal of the tumor. Or in children, we use the retrosigmoid approach. We don't have to remove anything. We just have a very direct approach to the CP angle, to the area of the brainstem where we are going to insert the electrode by means of the retrosigmoid. We do a conventional retrosigmoid approach. We monitor everything. We do a retroauricular incision far away. We create a big window trying to expose as much dura as we can. And the difference between this retrosigmoid approach and the one we do for, let's say, a removal of a tumor is that here we use a self-retraining retractor, because this is one of the key points of putting ABIs. When you do an ABI in these children, you have to be aware that you will probably not find a real 8th nerve. You will only have 7 nerves, but you will have 9th nerve that takes you to the choroid plexus. And if you retract the flocculus at the entrance or exit of the 9th nerve from the brainstem, if you retract gently the flocculus backwards and put there this self-retraining retractor, you will open widely Luschka's foramen and you will be able to insert the electrode. Here, once you have put the retractor, you see the ball, the little ball instrument pointing into the Luschka's foramen and disappearing inside Luschka's foramen just because of gentle retraction of the flocculus and opening of Luschka's foramen. And this is what we do to insert the electrode. This is the ABI of Medel. This is the one we use. we just trim it a little bit. This is a very short clip, less than 1 minute. Just trim it a little bit because this the anatomy of the child is usually not as big as in adult. And we put a narrow shape and we insert, you see how we insert deeply into the Luschkas foramen. We fix it with some non-resorbable material, and we push the cable anteriorly to allow the cerebellum to come back to its position and don't move the electrode. Of course, we do first a lot of clinical tests with the test electrode before inserting the final electrode. And I was telling you that our results are promising, and we think that this is a very good situation in these children. This is the result of one child we recently, well, we did 3 years ago, not recently, implanted. His mom is a doctor. She was very concerned about the situation, and we implanted him with an ABI with a nerve hypoplasia or aplasia. It was a doubtful situation, as we will see. We'll have this very often. And after 3 years, we have hearing results in all central electrodes from 4 to 9. So those central electrodes, all of them are producing hearing result in the children. This is what they say here in Spanish. In the central channels between 4 to 9, we have hearing results. The children is able to connect himself to the hearing world. Of course, this is not a cochlear implant, but this is much better than a non-working cochlear implant. So in a nutshell, and to make this brief, children with cochlear nerve aplasia or hypoplasia may still have functioning fibers, functioning cochlear fibers. So you must remember this, because even if there's no nerve on CT, on MRI, it may be a functioning fibers, nerve fibers of cochlear nerve. And if you have enough time, I think going for cochlear implant, starting with a cochlear implant is not a bad approach. But if you only have, as I said before, one bullet, if this is the last option you have for this child, then ABI should be considered as a very good option, because ABI in children do have better results than ABI in adult patients. Thank you very much for your attention.
Wonderful. Thank you, Javier, for sharing your experience. You're one of the few ABI surgeons on the panel, so that's very, very helpful. Thanks for that, Javier. We'll come back to you when we are going through the questions. So next, maybe Diksha or Anil, if we could play, I was asked, or Sunil mentioned to play Dr. Fatih Bhakti's video.
Yes, doctor, it's ready.
Yeah. So Dr. Fatih Bhakti, who came up with the concept of World Cafe, was meant to be in the panel, but he couldn't be here, but he sent in a video. So let's have a quick look at that, please. Thank you.
Friends and fellows, I'm Dr. Fatih Bhakti, Professor ENT, Alexandria Faculty of Medicine, President of Egyptian Society of Cochlear Implant, and former President of Cochlear Implant in Emerging Nations, which was held in Egypt 2 years ago, 2019. First, I would like to congratulate Professor Sunil Dutt for this mega event. It's a really mega event. And second, I would like to thank him for keeping the idea of World Cafe. He didn't kept it only, but he promoted it and he improved it a lot. So I would like to thank him. When I saw the agenda of the meeting of the panel of today on cochlear implant in hypoplastic cochlear nerve, I regretted very much for not being able to join you. But I realized that this is a great work which was prepared by a very good team headed by Professor Amit Kishore. So I would like to thank him for this great effort. And I wish for all of you the best of luck. And I'm looking forward to see the registration of your event and to see the proceeding of the World Cafe, which was very promoted by Professor Sunil. So again, I thank Professor Sunil, and I look forward to meet you again in person in any event in different emerging niches. Thank you and see you.
Great, thanks for that, Anil. Do we have Dr. Saad with us? Has he joined?
Yes,
yeah, and maybe Saad has sent in his presentation. So maybe if you could play that, please, Anil.
Sure, doctor. Just a minute.
Thank you.
Good afternoon, everybody. Good afternoon by Egyptian time. We now 3 o'clock in Egypt. Me, Dr. Saad Zayat, professor of ENT, Kafr Sheikh University. Thank you, organized committee, for joining this wonderful meeting about cochlear nerve hypoplasia. Generally, as we know, that cochlear nerve hypoplasia is a part of collective name of cochlear nerve deficiency. Cochlear nerve deficiency is a term. Cochlear nerve hypoplasia is a small nerve or aplasia absent nerve. This malformation has been estimated to occur radiologically in 0.8 and 1.8% of profound deaf child. Cochlear nerve hypoplasia was implanted in over our cochlear implant in about 2.5% of all population of CI. The most famous classification about nerve hypoplasia or nerve deficiency was by Kesselman classification that classified complete aplasia of vestibulocochlear nerve as a type 1 and type 2 vestibulocochlear nerve present but perceived cochlear nerve either aplastic or hypoplastic if associated with inner ear malformations type A, if associated with normal ear is type B. Radiologically, we estimate or discover hypoplasia or cochlear nerve by T2 weighted high resolution parasurgical MRI. The main guide of us is facial nerve that vestibulocochlear nerve of in supramontine angle or cochlear nerve in mid portion of pituitary canal, always the same with the facial nerve or larger in diameter, roughly by comparison of facial nerve. So radiologically, mainly we can diagnose hypoplasia of cochlear nerve by comparison by diameter of facial nerve, by MR as we see before, also by CT, not only CT, but measuring pituitary canal, roughly less than 2 millimeter, it is impossible to visualize cochlear nerve. When we discover this situation in deaf child, we do all full audiological test, battery, include subjective and objective, especially objective ABR measurement response. Electric ABR, Kesselman also notes that the severity of hypoplasia doesn't indicate correlation with outcome and recommended that CI assessment of children of cochlear nerve deficiency should include both pre and post pre-promontory stimulation by extracochlear electric ABR and post-implantation by measuring intracochlear stimulation through cochlear implant. Briefly, surgical management option may be CI alone or brainstem implant alone or both, either sequential or simultaneous. We'll discuss briefly the outcomes that published. Yamazaki et al. Reported that CI result in 19 children with cochlear nerve deficiency, evaluate important correlation between vestibulocochlear nerve size and intracochlear ABR as a predictor of outcome. They found that both factors independently correlated strongly with post-operative 1 or 2 year with CAP score. If vestibulocochlear nerve hypoplastic and electric ABR was poor, this was a predictor of poor outcome from start. Vestibulocochlear nerve greater or equal size of adjacent facial nerve with positive wave 5, at least 2 were predictor of gain benefit. Remember that curve is a category of auditory perception scale from 0 to 7. 0, no awareness, and level it is the about normal use of telephone as familiar thing. Use ABI. There is a first study have reported the result of 28 bilingual deaf child implanted with ABI. These studies have found less than successful outcome. 6 children of them no auditory perception. And even with perception, no child achieved CAP 5 or above. Another option, sequential CI and ABI in hypoplastic cochlear nerve. This mainly in young child, and as the first 6 patients with sequential CI and ABI was present in 2015 by Sonroglo. The mean duration of CI and ABI was about 2 years. Child appeared to have acceptable CI in threshold in the beginning, later become clear ability to have reached ABI was considered in these cases. Ideological performance showed dramatic increase when CI and ABI was together. The mean CAP score before ABI was 1, unsatisfactory, but after ABI surgery it was 4.8 as reported by Snowball. It is fantastic. Simultaneous CI and ABI when older child 3 or 4 years of age, the mean of ABI decrease. To avoid this, CI and ABI can be done in the same setting. The use of benefit of CI will decrease with the time. If child benefit from CIs, they will have bilateral simultaneous at the start. In case when CI not beneficial, the child not lose valuable time for waiting for ABI as theoretical thing. So this clinical pathway, I believe in it for management of cochlear hypoplasia and aplasia. Referral criteria: congenital deaf child less than 5 years, MRSU cochlear nerve deficiency, CT for internal auditory meatus, narrowing, child for general anesthesia, and all investigation was done using electric ABR. Successful, proceed for CI. If not, and the counseling for ABI, or if the patient refuse is out of criteria or discharged for this item. So conclusion in brief, even with today's technology, it is very difficult to predict the best treatment modality for cochlear nerve deficiency. Radiological and neurological evaluation method up till now not yet precise enough data when begin with CI and ABI. So usually not promising in all cases. Of course, often results for outcome CAP should not proceed with a sharp 5. When this candidate should give option of CI first, of course, and ABI either simultaneous or sequential, as we told you before. Finally, thank you for attention. And this is only brief point about hypoplasia management. Thank you again.
Wonderful. Well, we thank Dr. Saad for that presentation, and he will join us for the panel. I guess while we are waiting for Dr. Galal's technical issues to be sorted, once Anil gives me the heads up on that, maybe we could, or is it ready? Dr. Ahmad Galal, Assalamu alaikum, are you good?
Yeah, I'm good and ready. I had some technical issues with my laptop, unfortunately, so I had to resort to my phone instead, but I'm ready now.
Wonderful, wonderful. You have a backup. Great. So, well, let's hear your presentation, Dr. Galal. The screen's yours, please.
Okay, I already sent it to Dr. Neil, and hopefully he will play it while
yeah, I will just play it right away, Doctor.
Okay. Yeah, this is my brief presentation about cochlear implantation in hypoplastic cochlear nerve. I will talk about our experience in National Hearing and Speech Institute in Egypt. We have started the CI program since 2014, and for these 7 years we have done quite a lot of cases. We have done almost 725 cases up till now, and the rate is building up quickly. So we have more or less good experience with cochlear implant, but we don't have any experience at all with ABI. I don't know how, I don't think it gives good results. So let's talk about our experience, our personal experience in Hearing and Speech Institute in cochlear implantation. Next slide, please. Here is my institute. I would like to invite you all, if you come to Egypt, to attend in this great hospital. Next, please. First of all, approximately 2% of congenital profound deafness cases are due to cochlear nerve deficiency. I don't think that CT has a big role in diagnosing these cases. In such cases, MRI is essential to confirm nerve deficiency. But because of limitations with the resolution, it's often unable to distinguish between hypoplastic and aplastic nerve. A full audiometric assessment should be also conducted, and even electrically evoked auditory brainstem responses can be carried out transtympanically through the round window. If any test suggests the presence of a cochlear nerve, then we should go to CI and it should be considered immediately. Next slide, please. The aplasia of the vestibulocochlear nerve and aplasia or hypoplasia of the cochlear branch may occur isolated or combined with stenosis of the internal auditory meatus and or labyrinthine malformations. Next, please. And of course, if the diameter of the internal auditory meatus is less than 1.4 millimeter, an abnormality of the cochlear nerve should be considered. And if it's bigger than 3 millimeters, then it might indicate the existence of other abnormalities. So it's essential to have a good look in MRI at the internal auditory meatus and measure the diameter accurately. Next slide, please. Aplasia or hypoplasia of the vestibulocochlear nerve as one of the etiologies of sensorineural and congenital hearing loss can be diagnosed by MRI of fine cuts of the internal acoustic meatus, and based on clinical findings on MRI and embryological issues, Such entity can be classified into three types. Type 1, aplasia of the vestibulocochlear nerve associated with stenosis of the internal auditory meatus. Number 2, hypoplasia of the vestibulocochlear nerve with aplasia or hypoplasia of the cochlear branch. It may be either with or without malformations of the labyrinth. And the last, hypoplasia or aplasia of the vestibular branch of the vestibulocochlear nerve. Next slide, please. CT image of the temporal bone. Showing apparent reduction of the amplitude of the cochlear foramen to the left side. As you see here on the left side, cochlear foramen is almost closed, and with severe stenosis on the right side, we can see a normal cochlear foramen on the right side. Next slide, please. To talk about our experience in this subject, I have to share with you that between 2014 and 2021, cochlear implants were done in the hypoplasia of the cochlear nerve. These cases ranged in age between 20 months and 38 months old. 4 of these cases were females and 2 were males. These cases were followed up for 2 years post-operatively regarding speech and language development. Next slide, please. An example of a case done in our institute showing hypoplasia evident on the right cochlear nerve. And if we compare the right cochlear to the left cochlear nerve, we have a marked difference between the two nerves. Next slide, please. 5 out of these cases were implanted on the right side. 1 case was implanted on the left side. 4 out of the right side patients had bilateral hypoplasia with no observable difference between the right and left nerves. In the 5th case, MRI showed that the nerve is mostly aplastic on the left ear, so we had to go for the right ear. The last case, which was implanted on the left side, showed bilateral hypoplastic cochlear nerve with the left nerve better on MRI scan, so we had to go for this side for surgery. Next slide, please. 3 out of these cases were implanted using middle implant, 2 cases with advanced bionic implant, and 1 case using cochlear implant. Intraoperative telemetry results: 3 cases gave good response, 1 case had a bad response and was only 6 out of 12 electrodes. 4 cases gave good responses. This is unfortunately a mistake during writing. 4 cases gave a good response, 1 case gave bad response, with only 6 out of 12 electrodes gave response intraoperatively. But during first fitting, this case showed neural response telemetry for all electrodes. We usually use the first fitting between 3 weeks and 1 month post-operatively. The last case gave no intraoperative telemetry at all, but during the first fitting started to improve. With every programming session, there were, which is done at monthly intervals, improved until 3 months post-operatively, and gave good NRT for all electrodes with observable hearing response observed by the patient or the child. Next slide, please. Thank you. I just wanted to share our experience with the hypoplasia. Of course, I would like to hear your comments about, and if any questions, I'd like to answer them gladly. Thank you.
Thank you, Dr. Galal. We'll get back once we have the panel discussion, and we'll we'll discuss everything at that stage. We will now move on. And may I now request Dr. Neelam Vaid, please, to come on screen and share her presentation.
Good evening, everyone. At the outset, thanks a ton to the organizers of this conference for the opportunity to share a bit of our work with cochlear nerve hypoplasia. What I'm going to be presenting would be slightly repetitive. We have some presentations which have, already introduced some of the slides that I will be talking about initially. But what I'm going to be really focusing on is the outcomes that we have seen in these patients with cochlear nerve hypoplasia. As we know, and this data has already been discussed, about 18% of congenital hearing loss would have some issues with the cochlear vestibular nerve. Often these patients do have associated labyrinthine anomalies, and the focus of the outcome study that I'm going to be presenting is with those patients who don't have any labyrinthine anomalies, but just cochlear vestibular nerve anomalies. We do know that the MRI is the investigation of choice. Most of our patients underwent MRI with a 3 Tesla machine, and we do advocate that as the technology for better visualization of neural structures. However, when we looked at the outcome studies and we did a literature review, we found that a lot of the studies were not differentiating between did the patients really have hypoplasia or an aplasia of the cochlear vestibular nerve. And that was a big challenge when you looked at literature review of the outcomes of this. These were the various articles that we looked at. And as you can see that there's a lot of gray zone between these two definitions of is the nerve really present or is the nerve not there. There was this very nice article that showed us that the 3-dimensional magnetic MRI imaging on hearing outcomes with cochlear nerve aplasia. And this was the only one that we found which really showed that, yes, if you have children who were implanted with cochlear nerve hypoplasia, they did exhibit favorable results as compared to those which had no nerve visualized on imaging. The imaging protocols that we follow at our center are dual modality imaging. And we do use a combination of both HRCT and MRI. As I said, a 3 Tesla for the MRI and a 128 channel for the HRCT. The classification that we use is the old one that was promoted by Castleman and officials as far back as 1997. And this is the classification that we follow. For today's discussion, of course, we are going to be talking about type 2 CVN HSB, which is the hypoplastic cochlear nerve. When we looked at cochlear nerve and you looked at how do you really define, is this hypoplastic or is it not? The general consensus was you kind of compared it to the dimensions of the facial nerve. And this was the only one where we found some, I would say, anatomical references where we could say that is the cochlear nerve, it's supposed to be about 1.8 plus minus 2 millimeters or 1.6 plus minus 2 millimeters at these two levels. This was the only one that we could find where you could say, okay, you measure it, and instead of comparing to the facial nerve, you actually had a dimension measurement to say, is this really hypoplastic or is this a normal cochlear nerve in terms of dimensions? So the objective of our study, we looked at an assessment and a comparison of the outcomes of cochlear implantation in children with a hypoplastic cochlear nerve, and we looked at age-matched controls to see the outcomes in these kids. It was a prospective study. We looked at, we divided it into 2 study populations. The group A was the 10 children with cochlear nerve hypoplasia, and group B was our control, which was 10 age-matched children. All these children underwent dual modality imaging, and we used the Castleman's classification. Our exclusion criteria for this study was we ruled out any child who had an associated cochlear anomaly, if they had any additional disability in terms of either cognitive or other issues. All children that dropped out, that means they were not attending therapy at our center regularly, were not included in the study, and syndromic children were also not included. We compared their auditory and speech scores between baseline and 12 months. This study is still 12 months, and for the purposes of this evening's presentation, we looked at the data out of these 10 children that we followed up of cochlear nerve hypoplasia. We were fortunate to have data of about 6 of them at 3 to 4 years follow-up. And even though I haven't really been able to statistically evaluate that, I'll share a bit of what we found in those results. So as we said before, we compared them with the age matched controls, and the outcome measures that we used were the CAP score, the speech intelligibility rating, and the meaningful auditory integration scale. So we looked at the outcomes based on these 3 scores. And these were, of course, our children. As you can see, the age of implantation varied from about 2 to 5 years of age. These are just some graphs which have shown where we've achieved them in group A at baseline and at 12 months. The green graph shows you the scores at 12 months of habilitation, and the white is what we started out with pre-implantation. This is CAP and SIR. When you looked at a comparison of group A and group B, you're looking at group A, which was the cochlear nerve hypoplasia, and group B was the age-matched controls. We're comparing these 2 groups to see, is there really a difference? What we found in our results was that when you compared these children's baseline CAP scores and you analyzed it statistically using the Wilcoxon-signed rank test, we found that there was a statistically significant difference in these scores after 12 months of habilitation, which meant that CI in children with hypoplastic nerves definitely has a significant audiological and speech outcome, provided they are given habilitation for, this was a study for at least 1 year. When we looked at the differences between the age-matched controls and the children with cochlear nerve hypoplasia, we did not find any statistically different outcome. And that meant that the outcomes of CI with of cochlear implantation in children with hypoplastic nerves is comparable to those who had normal nerves. So that means that there is definitely a role of cochlear implantation in helping these children achieve hearing and speech goals. However, I'd like to put in a disclaimer here, but this was a study that only looked at their outcomes 12 months post-implantation. And as I said, when I re-looked at the data of those children that we've been able to follow up now at a period of about 4 years post-implantation, I must say that they have plateaued after 24 months. So all of them have shown a CAP score where we started out at about 1, averaging they are at about between 4 and 5. And that's what they reached at 2 years. But subsequent to that, there's a plateau. So at 4 years post-implantation, I'm seeing that the CAP score remains the same as what it was at 2 years. So that's something that we need to be aware about, that there is definitely a great gain and measurable good outcome if you look at these children's immediately post-implantation. But subsequently, I think it's a matter of discussion that they do plateau out. So I think to conclude, yes, we do know that these children will show variable outcomes, and there are a lot of other measures. But the thing is that when you compare it with age-matched children with profound hearing loss, they do show benefit, and that's a matter of debate whether that benefit is enough or not. Thank you so much.
Thank you, Neelam, for, as always, very clear, precise presentation. And may I now request Dr. Madhuri Gore to kindly come on screen, please. Ma'am, you're next, and Dr. Madhuri Gore has the honor. She might.
Please unmute yourself, ma'am.
Yeah, sorry, Anil, I think you'll have to, I want
Yes,
to.
ma'am. I will just.
Wait.
Can hear you.
Yeah, okay, I got it.
Welcome, ma'am. And
thank you.
saying that you have the honor, you may think it's a dubious honor or a otherwise of being
Sole audio.
audiologist on this panel, but I hope we're not making you uncomfortable. We look forward to hearing from you, because what you have to say is extremely important and pivotal actually in the decision-making process. So it's all yours, ma'am.
Thank you. That's a lot of responsibility. So, okay, let me just start without much ado. The main purpose of all the assessment is to find out what the child with the hypoplasia, cochlear hypo. Hello.
Can't hear. You have not opened your PPT.
Yeah, I have. Oh. You are screen sharing, it says. New share.
Yeah, you're sharing the folder. You have to go back to what you're sharing. And go to
now? No?
Yes. Yes.
Okay. All right. So, yeah. The purpose of all the assessment now, from the audiologist's point of view, is to find out what child with the hypoplastic nerve can hear, as compared to, usually think that the child can't do this with the hearing aid. So we want to see what exactly child can hear. And we will use methods appropriate to the age, that is getting pure tone thresholds or wobble tone thresholds with a conditioned or with BOA, VRA, and speech perception tests. In addition, we use non-verbal methods to test auditory perception, again, depending on the age, that is temporal perception, intensity, frequency discrimination, adaptation. And when we do that, we get the video recording so that we are sure, you can look and have a second opinion. The other part is OEs, emittance, reflex, and objective tests, ABR, ASSR, CAPs. Now, a big number of children with hypoplastic nerves do have OEs, or they, they appear to be like auditory neuropathy spectrum disorder. So we do that. And emittance and reflex, of course, are necessary. ABR, ASSR, of course, to confirm all the tests. And CAEPs, we use CAEPs to verify whether they are hearing with the hearing aid. So we might repeat the CAEP after the stimulation with the appropriate hearing aid, that is with a high gain and verified with REM. So the other part is that you may not see a lot of the information in the therapy session or during the session. So we use the parental interview, that is the Meaningful Auditory Integration Scale, ITMAS or CAP. And all responses in therapy are recorded periodically. A very comprehensive speech language assessment. So the other part of the children with cochlear hypoplasia is there many comorbidities associated, and their cochlear malformations. So we've had experience like the children having paresis or dysphagia, which was reflected in frequent hospitalization, pneumonia. So in the initial stages, we didn't know what the cause for pneumonia and all was, and other issues related to the chromosomal anomalies or syndromes. And there are related assessments for non-medical, that is speech language pathologists. So if you want to know what the child hears, you should know what the child says. So if they're having a lot of vowels, including the E vowel, then we are sure the child is hearing the second formant of E, which is near 2000 Hertz. and then occupational therapist, educator. So you actually need a very comprehensive assessment if you want to make a proper prediction. And so now from the literature, there is information that the degree of hearing loss can vary from moderate to mixed. So these are all the studies which have just found, and then even Meredith Holcomb found they were conductive, mixed, moderate, and probably this is related to the size of the nerve and profound. Mostly it is all profound hearing loss, and one of the few ones saying that they did develop vocalization, which means they did have some kind of a hearing. So now another aspect of which of the testing is we do a speech perception test. Now speech perception test, again, it is age related. You can have different tests, but this test I'd just like to highlight. You can just notice the words are like say dog, shoe, car, and then apple, auto, ice cream, and the third one is elephant, umbrella, and banana. So in this test, we see if the child can perceive the pattern of the sounds. Now, if the child can perceive the pattern, that is, if I say dog and he shows shoe or car, but not apple and umbrella, that means they do have a good pattern perception. So this is a very important test, and it tells what that the child is making use of his hearing. Okay, this is just the emittance and is the reflex present. And the next part is supplying the hearing, providing the hearing aid, and see if the whole speech spectrum available. And typically in children, we do a rear ear measurement and verify. So now the next part is that after the hearing aid is provided, we verify what the child is, what kind of changes that happen in the child's life. So I've added this gesture line down below, but even gestures change. So let's say if the child is beginning to hear speech and hearing sounds, they do respond in several ways, and one might be with gestures. So again, we have the standard tests and used very many kind of assessments. Sorry, it got repeated. The next, as children are younger and younger, then we just have to be sure that gesture is a very important aspect to be checked, because as Dr. Neelam just presented, you want to find children with no other comorbidities, then their communication is a very important aspect, and this is one part. So I'll just skip through things, but this deictic gesture is a very important part, that is pointing. So if you start acquiring the pointing, then you are very sure that other things are not occurring, and especially autism is one aspect. So if we see that the positive parts are that if the child is imitating vowels and the vowels are U, E are present, no consonants, still pretty good. If they're older children and they only imitate, it's very good. If they are younger and uses many gestures, at least, they don't seem to have other issues. But those young children with no response are something which we have to, think very carefully about. So imitation and the presence of vowels, eye contact, all those are good. For the older children, of course, their language and all that is, but we may not, now we get younger children, not so thing. Okay, so the referral criteria, this has been presented earlier and it is like a repeat, but basically you see that a rigorous assessment has to be done in to get all information about the child as a whole, and that is very important. So now the other aspect of evoked potentials is the Dutt and Kumar classification. Now TT-ABR is a very good way that we can assess very young children. Now when we used to get children like 3 years of age, it was a different set. Now you get younger and younger children, in which case you can do TT-ABR very quickly and do it. So you can see the montage and the golf club electrode on the left. And here on the right are all the figure of the morphologies. Here the description of the wave morphology is added. And of course, when the robust wave repeatable peak 5 and 3 and only peak 5, still they look good. And if the wave 5 morphology is fair, I was just discussing with Apurva, and he says that we can think they will get cross discrimination. And when there's poor or absent wave 5, then the decision has to be collective. So again, if after 3 months of consistent hearing aid use, if they have a good rest, these are all the positive aspects. You got a CAEP to sound. Cortical auditory potentials are obligatory, but they occur after stimulation. And suppose a child imitates, ba ba ba, and not versus ba ba ba, then they're getting a temporal perception. Older children, you can ask them to imitate beats on the drum. You make 2 and they make 2, or they sometimes show fingers. That's a little later, but they will imitate. And if the older child has pattern perception and we can do an adaptation, they do work, and some imitation in a closed set, then we are very sure that there is some hearing. So now that is for the cochlear implant, but then what about brainstem implant? So I don't have personal experience with brainstem implant, but some parts which were logical I discussed with the people who do brainstem implants, that is Nivita Narayan, Ranjit, and so here there are, so during the mapping, if there's no percept of sound, then and there is facial nerve stimulation before there's percept of sound, then it's a bad sign. Speech perception, DAT is discrimination after training. So even after training, there is no pattern percept. That is not good. Then aided thresholds are, even if there's a sound percept, it's out of the speech spectrum. There is no EABR or no cortical auditory potentials. And speech language, they may vocalize, but no improvement. So then they might want to go in for other options. Okay, this I'll skip the Burman, that is for mine. So let me just talk about our, Dr. Amit, how am I going on time? Speed up?
Speed up would be a good.
Okay. So this is our first child, which we were not sure with, but we took 3 months to get a proper audiogram, and that helped in the mapping because she didn't have any ECAPs. But later she developed a facial twitch, and then we had to go for a common ground. And here is another male who was later found to have a CHD23, and these are the responses, which took a long time, and he got ECAP only on 3 electrodes, but we could get a map. And this is a slide courtesy Apurva Kumar, where they were not sure whether there was a nerve or not. And then you can see that there was a TT-ABR, and then following that in the CI surgery, child got good responses. So this is the outcomes as per the category given by Burman, that is, aplasia 1, 2, 3, 4. And you can see the thing, but it is a lot similar to what Dr. Neelam presented and the other presentations where there's so many changes. So here I've got Nivita has kindly agreed to share shared some slides with me. So she's talked about few children, one with Michael's aplasia, cochlear aplasia, and ossified labyrinth, normal cochlea with cochlear aplasia, and NF2. And the non-auditory effects after brainstem implant were dizziness and eye watering. sound field thresholds appear to be within the speech spectrum, and there is awareness, but it is mode of communication is mostly total, and the NF2 and the there's one with the ossified cochlea who are verbal totally, but others mostly have close set perception. So, and the number of active electrodes are also indicated here. Yeah. Thank you. So,
Wonderful. Thank you, ma'am. We'll certainly get back to you at the time of the panel discussion. If I could move on to Dr. Naresh Panda, please. Dr. Panda.
Dr. Unmute, please. Thank you.
Yeah, good evening. Am I audible now?
Yes, sir.
Yeah. Thanks to the organizing team led by Dr. Sunil Dutt to have given this opportunity. I would be talking on a limited experience of treating cochlear nerve hypoplasia at our center. And as we know, the diameter of the cochlear nerve is significantly correlated with the spiral ganglion count. We know that the T2 weighted axial cuts in the parasagittal reconstruction using turbo sequence is used for assessment of the size of the nerve. And the mean, I think Dr. Neelam alluded to it, the mean vertical diameter of the cochlear nerve is around 1.1 to 1.4 as by Nakamushi and Jerry Zal et al. And many a times they may be associated with narrow internal altimeters less than 4 millimeters in diameter. Now it's seen in approximately 2% of cases. We came across 22 cases with cochlear nerve hypoplasia, either unilateral or bilateral. 10 cases had bilateral cochlear nerve aplasia. We could not do ABI due to some logistic reasons. 8 cases we saw who had unilateral cochlear nerve hypoplasia with a normal nerve on the other side, and cochlear implantation could be done with satisfactory outcomes. We had 4 cases with bilateral thin nerves. Cochlear implant was done, except in one patient with endochondral cartilage rest, which I would be sharing. And the results of cochlear implantation in cochlear nerve hypoplasia are satisfactory, but not too good. This is one patient who was operated in 2016, and assessment at 9 months of implantation achieved a CAP score of 4, was able to express in single words. The SIR scores progressed to 2 by 9 months. Her listening age was around 2 to 5 months as per the developmental scale. The meaningful auditory integration scale was from 0 to 20 within 3 to 6 months. However, the current assessment in September 2021, that is after 5 years, did not show, in fact, the progress which she had achieved in the initial 9 months had plateaued, and it's almost the same now. So that means it was probably because of the parents' job profile, reluctance for the smartphone usage, for rehabilitation, distance from the center, and the corona pandemic could have played some role in poor outcomes. The other child, this was a little interesting, had bilateral cochlear nerve hypoplasia. At implantation, she had shown good NRT values. The impedance was normal, but there was one abnormal thing which we could see, and that was all the negative peaks were not there. In fact, it was only the positive peaks. The negative peak of the action potential was conspicuous by its absence. However, later on, they came back to little normal. The negative peaks were seen, and after 1 year, she had a CAP 11, a level 6. The post-op aided audiogram and the condition-aided responses were within the speech spectrum, and she showed a satisfactory response in audition, receptive language, expressive language, cognition, and pragmatics. I would share one interesting patient who had persistence of endochondral cartilage, which was encountered at surgery. This was a 5-year-old child with bilateral severe sensory hearing loss. They were absent wave 5 in bilateral ears. The computed tomography and the magnetic resonance imaging showed bilateral thin nerves. The mastoid cavity showed few lucent areas amongst the air cells. That time we just did not imagine that we are going to encounter something abnormal. And this was the lucent areas, the bilateral thin nerves at 0.6 and 0.4 mm. This was the histopathology, and I'll just share the video. And when we opened, this was all cartilage. We could not see any of the anatomical landmarks. We drilled for a while, thinking that some anatomical landmark would be visible. And after some time, we discussed with the parents, who did not give us consent, because otherwise we had an option of doing remove the canal wall, do a blind sac closure, try to explore more for the anatomical landmarks, and go ahead with the cochlear implantation, which ultimately we could not do. So to conclude, cochlear implantation in hypoplastic nerve should be considered for the optimum benefit in hearing. They should be closely followed audiometrically and language assessments to monitor benefit. Size of the cochlear nerve may predict the outcome of cochlear implantation. Some children showed early promise in auditory performance, but plateaued later on, and associated anomalies could always be encountered in these patients. Thank you very much.
Thank you, Dr. Panda, for sharing your experience. Could we now please move over to Dr. Shankar Medikeri, please, for his presentation? Dr. Rambabu, am I correct? You don't have a presentation to make?
No.
Yeah, it's the fault is actually at the technical end, because
Yeah, I think so. There was some. Yeah, I missed it out.
Correct. No, yeah, there was a technical glitch. I think the emails that were going on were not reaching Dr. Rambabu, and we didn't allow him adequate time. So we are sorry for that. I will apologize on behalf of the.
Am I audible, Amit?
Yes, sir. Yeah. Good. So Dr. Medikeri, I think, has got the last presentation, and then we will, after 5-7 minutes, we will rush, go through all the questions, or some of the questions that we.
Thank you, Amit. Our cochlear implant program is about 17-year-old, and we have about 777 implants to our credit. More than 95% are pediatric. We had a total of 12 cases of hypoplastic cochlear nerves with or without cochlear anomalies who underwent cochlear implantation at our center. We had 4 cases, 2 of which were microplasia and 2 were cochlear nerve aplasia, which we referred to the other center for ABI, as we don't do ABIs at our center. So coming to these 12 cases, what we had, so if we go through these 2 charts, which I'm showing here, so there were some with the normal cochlea and there were some with abnormal cochlea or a cochlear anomalies. So as you can see, the one with the normal cochlea and the hypoplastic cochlear nerves, the outcomes have been quite good. Means the children have been becoming oral, verbal, speak sentences and understand the commands quite well. Whereas we had one case of incomplete partition type 1, whose video I'll be showing, with a mild hypoplasia on right side and gross hypoplasia of the nerve on the left side. We did a right cochlear implant, and she has developed a very good speech and language and is attending the normal school. Whereas those with incomplete partition 2A with the hypoplastic cochlear nerve have also done quite well, though not like the normal children or the normal cochlear nerve people, but they have developed a good clarity, was to be affected a little bit, but they had a good awareness, and as well as some were though requiring visual cues at times. The cases with hypoplastic cochlear nerve, as you can see here, are the ones which have not done very well. They took a long time to progress, and they were speaking in small sentences, and they need to have lip reading for the comprehension. And there was one case of bilateral incomplete partition type 2A with a hypoplastic cochlear nerve who underwent right cochlear implantation. This child was doing reasonably well in the first year, but the implant got infected at the end of 1 year. And in spite of our persistent struggle, we were not able to save that implant. Ultimately, that implant had to be explanted. And unfortunately, the other ear was not implantable because of the absent cochlear nerve. The worst scenario was in the case with the bilateral common cavities with one side hypoplastic cochlear nerve and the other side absent cochlear nerve. The progress has been very, very slow in this child. It is only having an imitating sounds with auditory oral approach, and it just identifies few objects, otherwise no further progress at all. So now I'll be just sharing 3 of the cases with you. The first case was of a normal cochlea with hypoplastic cochlear nerve. This female child, in spite of adequate use of the hearing aids and consistent speech therapy, they were not getting benefit. And the child had a normal facial function on both the sides, and her HRCT showed a double internal auditory canals. And the aided audiometry, as you can see here, unaided and the aided audiogram, the right side was quite below the speech banana, whereas the left ear thresholds were quite within the speech banana, except the 4000 hertz speech frequency. This is the CT showing a thin double auditory canals. This was the same type in both the ears, and the MRI of the internal auditory canal showed only one single nerve. To mind you, this child had a bilateral normal facial nerves. So obviously this nerve in the internal auditory canal would be the facial. But still the child was showing auditory responses. There's a possibility that, as mentioned by earlier speaker, there is a functioning nerve which might be passing through the facial nerve itself. We don't know. So that is how it was giving a good response even on pure tone audiometry, what you saw. So that is why we submitted this child for a further audiological evaluations like the 6-link sound test and as well as the early speech perception tests, which clearly showed that the left ear was doing much better as far as the word identification and repetition of words, as well as pattern perception or a bisyllable identification or vowel identification compared to the right ear. So with this, before advising any advice, we did a transtympanic ABR in this patient. To our surprise, we could see a better wave formation, early appearance of the wave 5, and a good amplitude in the right ear as compared to the left ear. To tell you, really, this child had a better aided responses in the left ear and not the right ear. Right ear aided responses were quite below the speech banana. So because of this, we continued the child to use the hearing aid in the left ear and implanted the right ear with the nucleus 5 contour advanced electrode implant. But on the table, we had NRT only for the 9 electrodes out of the 22. But later responses were observed with the post switch on with CP810 processor. This child managed to improve her speech and language after 6 months, but unfortunately after 10 months, because of the technical failure of the nucleus 5 implant because of hermetic seal issue, this child had to undergo explantation, but was re-implanted with the Freedom Contour Advance. And later on with further AVT sessions, she developed a reasonably good speech and language, and she has been attending normal school now. And recently she has upgraded her processor to the nucleus 7 implant. And this is the second child with bilateral incomplete partition type 1 with hypoplastic cochlear nerve. So as you can see, there was not much benefit with the hearing aids. And again, this pattern perception and speech perception tests which were conducted, which again clearly showed that the right ear was doing extremely well compared to the left ear. In this case, the child also had a good IQ and good developmental quotient. So as you can see, the type 1 anomaly of the cochlea with a very hypoplastic nerve on the right side and not very grossly hypoplastic on the left side. So this child, we did a right-sided cochlear implantation again in 2018. So with a cochlear straight array in this case. And as you can see here, so after 1 year, post the aided thresholds with the cochlear implant are quite well within the speech banana. So I'll just click you just a few seconds of this. No, I can't say it's a very excellent speech language, but looking at her pathology of type 1 anomaly with a thin cochlear nerve, I think she had a very reasonably good improvement, and she has been attending normal school also. The final case, third case, is a case of bilateral incomplete partition type 2 with a cochlear nerve hypoplasia on the right and an absent cochlear nerve on the left side. So this patient had both unaided and aided responses good on the better on the right side compared to the left side, though the aided responses were outside the speech banana. And as you can see, there was a thin nerve showing on the right side, but left side, the cochlear nerve was not identifiable. And as you can see here, we operated on the right side implanted with the AB 1J electrode, advanced bionics. You could see the hole. We were able to place all the electrodes inside, 16 electrodes. This is a post-op CT, which you can see. So, and this child on the table, though the impedances were normal and all the 16 electrodes were inside, we got the intraoperative neural responses at very high thresholds, and that in only one set out of the 4 sets. But post switch on, there was a behavioral responses to sounds, and this child, few days after the switch on, showed neural responses on 3 sets at the lower levels. And she developed good awareness of sounds in few post switch on days and a conditioning responses, and she has shown a good improvement in communication skills, listening skills, as well as receptive and expressive language skills. So coming to the conclusion, I would like to say that cochlear, CT temporal bone alone is not likely to identify any cochlear nerve hypoplasia. So high resolution MRI of the brain and the internal auditory meatus, especially the oblique sagittal views, are more sensitive in identifying the cochlear nerve hypoplasia. Especially one should take a 0.4 or 0.5 mm thick cuts. And whenever diagnosis of cochlear nerve hypoplasia on MRI is definitely a significant, but it does not rule out the possibility of cochlear implantation in these cases. So detailed audiological evaluations, including the EABR, should be done before guiding or advising about the cochlear implantation or auditory brainstem implantation in these cases of cochlear nerve hypoplasia. Cochlear implantation should always be considered prior to ABI in these children, especially when the auditory responses are present. So because we don't have any experience in the auditory brainstem implants in cochlear hypoplasia, I don't have any additional comments to make. Thank you very much.
Thank you very much, Dr. Medikeri.
Thank you.
So I'm going to share my screen. I thank all the panelists for sharing their very valuable experience. And in this process, I've tried to make some notes, and we all have a set of questions. Now, the aim of this discussion is for us to come to some sort of an idea at the end of it as to what we should be putting into our recommendations or presentations that we make a few days from now. So without further ado, I'm going to run through some of the questions that we've already shared. I will probably make some comments or some assumptions that we might have gleaned from the talks. And then after that, I might ask the panelist for a specific panelist for his or her comment. If the other panelists have anything to add, then please do say so. There's no request you not to repeat what has been said already, because we have very limited time. So we'll try, I and panelists, we all will try and be very, very brief. Now, the assumption for this for this topic is that we are dealing with pediatrics. And of course, all these kids would have met the criteria for a cochlear implant in that they have a severe to profound hearing loss. They've been through the whole process, and we as a team would have decided that this child would be a candidate for a cochlear implant. And of course, the age would be appropriate depending on our protocols. We are also assuming that the cochlear anatomy is normal, because hypoplastic cochlear nerve or nerve deficiency with cochlear visceral anomalies is a different ball game altogether, and that complicates the matter. So we'll just restrict to that. And of course, once you've done the imaging, we have come to the finding that the cochlear nerve may be deficient or hypoplastic. So that's our starting point. Now, the first thing is what we need to decide is, how do we, what should be the definition for a hypoplastic cochlear nerve or cochlear nerve deficiency? Neelam has pointed out that lots of the literature has an overlap where they club in the absent cochlear nerve and the hypoplastic cochlear nerve in one, which muddies the water and can make things difficult. So, of course, MRI is the mainstay because that's where we're going to see the nerve. But what about CT scan? I know that in most centers in India, we are dual modality, both MR and CT. Javier, can I ask you, are you doing CTs as a routine in your assessment for children for a cochlear implant, or you just rely on MRIs?
You mean in these situations or overall?
Overall, and then in both. So you have a child. I mean, would you do both in the first instance, or you would do a CT scan only in certain situations?
We use CT scan only for patients that are going to be treated surgically, that are going to have a cochlear implant. So before that, we do just MRI. But in cases with suspicion of hypoplasia or aplasia, we always do CT and MRI. CT otherwise is just kept as a second tool because it's not harmless.
Yeah, so correct. So now my question is that when we are setting up or we are recommending, should we be bringing in, because we have brought in factors, there are some definitions of a CT scan with the internal canal being less than 2 millimeters or 1.8 millimeters. And what about the concept of the cochlear nerve canal? So the cochlear aperture stenosis or the bony cochlear nerve canal, because we have seen I've seen situations where a hypoplastic nerve has been missed, and the CT scan very clearly shows that the cochlear nerve, the cochlear canal, is stenotic or is bony. So would somebody like to tell us whether we should be including CT criteria when we are classifying these patients? Maybe Neelam, would you like to answer that?
I think as a recommendation, if you're talking just about hypoplastic cochlear nerve and we're looking at just that entity, then it has to be MRI. When you are talking about all the other conditions that we are seeing on CT, like you mentioned cochlear aperture stenosis, and you mentioned a very narrow, internal artery canal, these are associated with other anomalies usually. I mean, in a very narrow internal artery meatus, for all you know, you have a complete absence of the cochlear nerve. So I think if you're looking at just defining which is the imaging modality to diagnose hypoplastic cochlear nerve, then it has to be an MRI. But we have to put in a disclaimer that one has to remember that there are limitations of imaging, which would be more applicable to when we say aplasia or an absence of the cochlear nerve, not so much for a hypoplastic cochlear nerve. Yeah. So in my opinion, it should be MRI, which should be the recommended imaging. And of course, then we can put in a further definition of what do you really call hypoplastic and what do you say is not hypoplastic.
So MRI, of course, as I said, MRI is mandatory because that's going to give us a soft tissue. But does
no, I don't think for hypoplastic cochlear nerve really, Amit, a CT is needed. Again, we've got to see where we are going. If the group or the panel today is just making recommendations for hypoplastic cochlear nerve, then it's got to be just alone MRI. But in general, come on, for cochlear implantation, we do talk about dual modality. So most of them will undergo both the
My point is what you had actually mentioned, that there's a lot of overlap. So a lot of the times, so you do an MR and, of course, we see it's hypoplastic or aplastic. So does the CT add? Because if you've done a CT scan, you find there's also bony canal stenosis. Then, that corroborates the fact that the nerve, which you cannot see on the MR, may actually not be present at all. So, because when we start, we don't know that the child has got a hypoplastic nerve. It could be aplastic, because that's going to lead on to my next question is which way we go. So, when we're evaluating somebody with a dubious cochlear nerve, is the question is that would a CT add value? And that's where I'm coming from. Is if the canal is narrow, if the bony cochlear aperture, if the cochlear aperture is stenotic, then it probably goes more in favor of the nerve being absent, and might alter our decision-making process. Anybody on the
Can I interject, Amit? Hello?
Yeah, please, sir, please.
I think I would agree with you, because anyway, we are resorting to a dual modality. We have both the CT scan and MRI, and if we have the internal altimeter narrow, if we have a narrow cochlear aperture, and in addition, we have we can collaborate with the MRI findings. I mean, it adds to the diagnosis. I mean, there is no harm in not doing a CT scan, though Neelam is correct that for definite diagnosis of a hypoplastic nerve, MRI is required.
Correct. Yeah, I agree with that. But here the problem is that because sometimes we are trying to differentiate. If there's an aplastic nerve, then we may, like Javier said, we go straight for an ABI. So anyway, so MRI, of course. Now, should we go with the definition that has already been discussed about the size of the nerve on the MR and the comparison with the facial nerve that has been come out in a few presentations? Are we good with that?
I think both. We mentioned that, yes, we can do an eyeballing and say, yes, you compare that with the facial. But if you have a radiologist who can give you dimensions, then that also adds to it. So I think we should put in both the criteria, both the dimensions and the
comparison
and the eyeballing and comparing it with the facial nerve.
Right. So we are aware, we come to the classification, because at the end of the day, we all, as we know in literature, we should be all talking the same thing. Again, coming back to your point about overlap. So we should encourage that there should be a classification system. We are all aware of Castleman classification. Dr. Gore mentioned the Berman classification. So any thoughts on that? Should we stick with, should we recommend just Castleman or Berman or both? Very quickly, anybody to comment on that, please?
I think let's stick to the Castleman. It's the one that's followed generally for all publications.
Yeah.
So I would say Castleman.
Castleman.
Javier, anything different to add? Is he there? Have we lost him?
Sorry, I was telling you that it's a difficult question for me, because you are going to get a very difficult answer. I don't like any classification. I don't think classifications help at all to decide on a single patient. It's good for papers, for statistics, but to decide what to do with the patient, I don't care if the classification tells me something or doesn't tell me something, because what I'm going to do is just to act according to the evolution of communication, language, hearing aids, so many other factors. So I'm not a friend of classification at all, not for malformations, not for hypoplasia or aplasia. It's so difficult that for me this is useless.
Okay, great. Now, what should be our recommendation for the appropriate parameters? Now, this should actually be asked of a radiologist as to what should be the correct settings or the parameters to get the best imaging that we currently have, in the given technology. We have, yes, a 3 Tesla 3 Tesla MR and a 128 slice CT if you're doing CT scans, parasagittal sections and all that. And Neelam has enlisted all. So are we good with that, or should we be more specific?
So Amit, I did ask Sanjay about this because I read this question, and yes, I mean, ideal would be a 3 Tesla, but that does not mean that a 1.5 Tesla or even a 1 Tesla cannot give you the images. I think what one will need to define over here is that if you're using a 1 Tesla or a 1.5 Tesla, then the radiologist has to use what we call surface coils.
Right.
That's what enhances the good images. And if you're using, of course, a 3 Tesla, then that's perfect. So I don't think here let's really insist on a 3 Tesla, because there would be a lot of centers, at least in our country, that may not have that. Even though it is soon becoming the MRI of choice. So let's just put it down there that if you're using anything less than a 3 Tesla, then a recommendation would be for imaging to be done with surface coils.
And we all need oblique parasagittal images.
Yes.
Right. So the next, and I think this is probably very, very pivotal when we are faced with a situation where the radiologist tells us that the nerve is either hypoplastic or aplastic. Now, we are going with the fact that, okay, there is some cochlear nerve abnormality for now. And Dr. Gore has very given details of all the audiological assessment. Sorry, somebody want to say something? No. Okay. So now, in terms of the minimum recommendations, my take from your talk, your presentation, Dr. Gore, was that yes, we need good quality, reliable, conditioned, aided assessment. You're using the questionnaires, parent progress MACE, ITMACE for the very young children. You've also highlighted the non-audiological assessments, and rightly so. So my point here is that, taking all that what you have mentioned, what about hearing aid use? Now, of course, these are kids who are not getting benefit with hearing aid, but my question was, what further information will help us as a team figure out whether there is functioning nerve fiber? At the end of the day, as was mentioned, the whole idea here is that there could be functioning cochlear nerve fiber traveling somewhere down the pathway, which we are trying to capture. And if we have evidence of that, then we are likely to opt for a cochlear implant. So you've mentioned, I'd like you to elaborate on that for a minute.
Yes, sorry, there are crackers here.
Okay. You're celebrating Diwali, wonderful.
Yeah. Okay.
So my and I'm going to put all the questions together, because you mentioned cortical potential, but the trouble is that most of us, that is only available at institutes. Most of us will not have access to cortical action potential. So that's great for institutions, but what about the bog standard cochlear implant team? How recommendations for them?
Okay, maybe we should go to the next question, and I can't mute the crackers.
May I say something till the crackers at Madhuri's place goes down? I think just because we do see a lot of this, and you mentioned in other places which don't have access to great audiological testing, I think one thing that we need to put down here is definitely expectation questionnaires. That's something that I would really like in the assessment, as to what is the parent expecting from an intervention. Definitely a hearing aid use does have advantages, even in these situations, because what I need my therapist or my audiologist to get back to me with is there any response that the child is getting with the hearing aid? So the hearing aid use or the hearing aid trial does still remain, even though you may not be expecting anything, a very important criteria, at least for us, for decision making. Because if you're getting some audiological responses behaviorally, then that's a positive prognostic indicator.
Yeah, I think that's what we do. Anybody?
I have something like what Neelam has said, exactly correct. That's what we follow. some part of hearing aid artery gain. Then we also do, I don't know how far this is not being mentioned, but at our center we do LLR, and to get delayed response, late latency response, which is quite well corresponding to our results also. I mean, the delayed response extension of the ABR, it is giving LLR. Probably Madam Madhuri Gore can elaborate that. Because our center, we follow that. We don't have facilities for trans-tympanic EABR, but we do follow LLR values, I mean responses, cortical responses.
Comment on that, Dr. Gore?
Can you move to the next and come back, because this doesn't seem to be ending so quickly. Sorry about that.
Okay. So, next, you mean the trans-tympanic EABR, or should we go to a different topic?
Trans-tympanic.
I think she wants you to move away from audiology.
Can we wait, because the
later.
crackers are still going on? I'll just go out and have a look and see where, what is the state. Just 1 second. Sorry about that.
Fair enough, fair enough. Okay, I'll move to, because Javier mentioned the intracochlear test electrode. So we'll come, Javier, and maybe our colleagues from Egypt, anything that you want to add to the audiological evaluation that you do at your centers when you're making that decision?
Well, I think it's little to add. I mean, we have covered everything. What I would like to say is that this, to us, this is real important. I mean, more than classification, what we rely on is on the evolution of the patient, and this is given to us by the audiologist, not by the radiologist as a classification. Therefore, I think the evolution, all kind of audiological tests, the hearing aid use, so the advancements with the progress that the patient does with communication and language, this is very important. Number one, to decide whether to go for an implant at the beginning, but mainly if we are using a CI and the CI is not giving a very good result, just to decide when to move to perform an ABI. And I would add anything. I mean, this is a complete, as complete as possible audiological information.
Perfect. Yes, I agree entirely. And I think we are very, very reliant on our audiologists and electrophysiologists to help us. Javier, I'm going to keep you there. Now, you mentioned the intracochlear test electrode in the decision making. So first of all, let me ask you, do you do trans-tympanic EABRs as a routine in questionable cochlear nerve situations? That's
No.
my first question.
No, we don't.
Okay, so we rely more on the evolution and behavioral responses, etc. And what's your experience? I'm aware of the intracochlear test electrode. I don't have access. I mean, we have an ABI program, but I don't have access to that right now. But do you use that again almost routinely when you are when you've decided to consider a child for an ABI? Do you always use the cochlear test electrode before you go to an ABI in the questionable situation?
Not in children. I mean, we use it very often, almost routinely in NF2 patients and adults after tumor removal and preservation of the cochlear nerve, just to assess how is the situation of that manipulated nerve during so much time during the surgery. For kids, we rely more on imaging studies and evolution, as we said already, and we seldom use the intracochlear electrode, test electrode for children. In adults, it's very useful. And in children, of course, I mean, if you use it, if you are deciding whether to use a CI or an ABI, you still have time. The use of the intracochlear test electrode may give you a good response. If you get a good response, okay, this supports the idea of doing a cochlear implant. If you don't get a good response and the clinical scenario is focusing on ABI, I will not change my idea of ABI. If it's on CI, I will not change my idea of CI. So it may support my idea of putting an ABI, but I will not change from one side to the other just because of a failure of the electrode, test electrode in children.
Okay, so you would use it if you had to, but you don't find that it's robust or reliable enough right now to go against your clinical judgment that you've taken so far. Okay,
exactly.
Good. So we'll come back to the other TTABRs and things once the fireworks have
they've subsided.
It's quiet there. There you are, Dr.
Yeah.
Okay, so are you good to answer that? So we were just going over getting information with hearing aid. We were talking about the fact that we all would like to get evidence of some aided responses, albeit of course below the speech banana, but some evidence of aided responses on reliable assessment to give us that confidence that there is a functioning nerve. My question is that, of course, not everybody has access to cortical responses as you would. So maybe a minute to elaborate on that. You've talked about TTABR. Again, some of us have used TTABR in our decision making, but not everybody has access to TTABR. So considering that situation, which is probably for the majority right now, just a couple of lines on the key things that the audiologist that we should put in the recommendation as to what would be good positive predictors towards a cochlear implant.
Yeah, see, if that child can be conditioned reasonably well, no, you get consistent responses, and that takes time to condition them. But if you do get them, then I'm very happy with that. And parent progress, we do see that. The other part is the speech. If they are beginning to use their voice and they're beginning to say some, I mean, okay, they're just beginning to use their voice, I will take it as very positive sign, because only if they start hearing, they start using their voice. Even in imitation or any kind of level, others, they will not use the voice without a prompt. And the other thing is, you can, now I'm talking about, see, in the therapy, during the stimulation, you talk about different kinds of sounds, and then you see, are they getting the temporal sound? So are they getting, is the sound a brief repetitive, or is it one long sound? So this you can get information. It takes time, okay, but I think it is worth waiting for that and not be in a hurry. Then if you're in a hurry, then you have to do electrophysiological like TTABR. Our experience has been good, but as you said, it's not available everywhere. And cortical evoked potentials, I think we are getting there, but okay, right now we don't have, but a behavioral response, if it is there, it will correlate with the cortical evoked potential.
Correct.
Definitely.
So the point you rightly mentioned, with Javier also mentioned, is the time and the age. If we have a very young child, we have time to assess, both with hearing aid or post CI. The
3 months of hard work, you'll get it.
The trouble is, if they're coming to us at the age of 3 or 4.
Not 3 years, if they come, you can't wait 3. I mean, we can wait 3 months. I think it is quite okay.
So I want to ask you, because we have had some experience with TTABR, thanks to Apoorv, you've had experience. So how would the findings on your TTABR alter your clinical decision? So let me rephrase that. Your clinical decision, it looks positive, but you don't get very much on the TTABR. So of course, everything correlates. It's fine. You've got a good behavioral response. You have good responses on TTABR. 1 + 1 = 2. So that's fine. But what if it doesn't happen? So how sensitive or specific have you found it? And would you change your decision based on that? Because Javier wouldn't. So I'm asking you if you would.
We haven't had, I mean, even Dr. Medicare is here, but so far we haven't had any, it has matched with what we have found. We've had some 6 cases, Alva, TTABR.
Yeah. When we have a good response on TTABR, so that will make us more positive to go ahead and tell the parents that there could be a chances of very good outcomes. But if the TT-ABR is negative, if you don't get a very good responses, wave formations, then we are not sure whether how the outcome will be.
I'm asking also my colleagues from Egypt, Dr. Saad and Dr. Galal, because see, we've all seen this flow chart that has been, as one of the publications. There's a flow chart that if you don't see a nerve and then you get responses on EABR, you go ahead for a cochlear implant. But if you don't, then you jump straight to an ABI. Should we be recommending that? Because that's quite dogmatic. Anybody on the panel to say yes?
I am not sorry. I'm sorry to jump in, but I think, ABI will take very, very, very carefully the decision. At least that is my personal feeling. And we just see the review that very, very carefully. And then only I would be very hesitant to recommend ABI very easy, fast.
I understand that. But my question is that based on that flow chart or paradigm, they're relying very heavily on EABR. So to make the decision, and that's what I'm bringing up.
So we repeat, wait and repeat.
Amit, if I may, I think I would agree with Javier. At the end of the day, the one that's going to really make your decision is going to be the behavioral condition responses. The TT-ABR by itself is not going to add anything. So coming to the scenario where you said you're getting behavioral responses, but in TT-ABR, you're not getting anything, I'm going to go by what the behavioral condition responses go. The TT-ABR is not going to be a major decision-making in my evaluation. So if at all, if you're saying a recommendation, we say it adds, but it's not the decision maker. That's what
I would agree with that. I would think too. Dr. Saad, Dr. Galal, anything that you want to add? Just please pitch in. Okay, so all quiet from the Egyptian front. So so now very, very quickly, when we are coming to there are certain situations when we will definitely go for a CI. So let me go over that. If we see a nerve on the MRI, albeit hypoplastic, we all agree that we will recommend a cochlear implant. We would not be looking at an ABI. Is that correct? Or anybody disagrees with that?
Yes.
If we get good behavioral condition responses, our audiologists tell us that yes, there is a good response on the with the use of the hearing aid, and if you have a TT-ABR that's positive or cortical is positive, if he or she reassures us, even though the imaging may be dubious, then we go for a cochlear implant. Is that correct, or any disagreement on that?
I think we should specify what behavioral. If you just say thresholds, that is not sufficient. I would see the next level if they have some kind of discrimination and some kind of
perception. Okay. They should be. You should
not just thresholds. Yeah.
Okay. Right.
Just a question, Madhuri, would they really get discrimination with just maybe 3 months of a hearing aid trial?
No, it's like everyday very rigorous training. They will get.
But still at 3 months with a cochlear nerve hypoplasia or even with rigorous rehabilitation, are you really expecting discrimination in 3 months?
Yeah, what discrimination? We are looking at temporal.
Okay, just temporal.
Yeah, temporal.
Okay. Yeah, I think
they won't get frequency. They even intensity. Temporal.
So I think we need to maybe specify temporal, because most people will look at frequency.
No. Temporal.
Madhuri, what about pattern percept? Would you get pattern percept in that period?
Pattern percept, older children, if they've used it and they've had enough language exposure and all, then they will get pattern percept. That is also temporal only.
Okay. Yeah. Sure. Okay. So that's that. In which situations would we certainly not advise a cochlear implant? Now, normal cochlear anatomy, and of course we don't see a nerve at all on the imaging. There may be some fibers traveling through, we don't know. And maybe if our audiologist tells us that the child's just not getting anything on the hearing aid, there's not even a detection threshold after a few months of use. Would we be fair to say that it's not worth considering a CI? I know Javier has said if the child is young, they would still do a cochlear implant. Maybe I'll ask you, Javier, if you have a situation where there is supposedly a deficient or aplastic nerve, and the child is not, your audiologist tells you there's just nothing on their detailed assessment, should we still consider a cochlear implant, or would we just say then there's not worth considering?
We will not consider a cochlear implant on those situations. In fact, most of our ABIs are on patients with theoretically aplastic or hypoplastic nerve without any response to stimulation. So I wouldn't reject from start the idea of an ABI. What I say is that if there is any doubt and there is time, cochlear implant is a good option, as long as the patient and family, they understand that this is just the first step on a way to a maybe second step on an ABI. Unless there is nothing that you can rely on, I will start with a cochlear implant.
Okay. So is there any other situation, any of the panelists would like to add any other situation where we would not advise considering a cochlear implant, apart from what we've just discussed?
With normal anatomy?
With a normal, yeah, we're talking normal cochlear anatomy. Normal cochlear anatomy, we've talked about the fact that you don't see a nerve on the MRI. Your audiologist tells you there's nothing there. So then that's like you've said.
Comorbid situation, conditions, there are a lot of other issues. But we are not talking of anything.
Okay. Yeah, so comorbidities, if they have other, you're absolutely right, you brought that up. So if they have other comorbidities or developmental issues, then just not advising an implant, not advising a cochlear or anything is absolutely right, particularly so in ABI, because that is one of the very important factors when we are moving towards.
I think I give sign language, yeah.
Yeah, sure.
I think for me, it would be very important to see what are the parent expectations and their commitment. That would be a big decision maker for me.
Absolutely.
If I have a family that's expecting, phenomenal results, and in the pre-evaluation, we are seeing that their commitment to therapy is not so great. And that's where the hearing aid use for 3 months really helps you, because you're seeing what's their commitment to therapy. For me, that's a no-no. So for me, that's really an important decision maker.
No, absolutely right. We'll come to that, because that's what that's very, very important here. So we use the word diagnostic therapy in our situation, because we want to see not just what the kid is doing, but what the parents are doing. So coming to the next one, which Javier mentioned that we all talked about, that now in some situations we'll go for a CI first and then we'll go for an ABI. Very quickly, Javier, you said time. So what is your criteria in terms of time or age, wherein you would say, okay, we have enough time, let's try a cochlear implant as the first stage, and then we move to ABI, or no, it's too late, we don't have time. So you did mention that. Could you specify for us, please?
Yes, I think it's not easy. Amit, it's something that depends a lot on the situation of the family and the patient. But as a general rule, you will need, if you put a CI and wait until you see the results before you decide to go for an ABI, that will take, let's say, about a year, 8 months, 10 months, a year. Just put a year. So what will be the last time you will want to implant a kid? 5 years? 4 years? So after 3 years of age, if you start with a CI and it fails, you will be maybe too late. So 3.5 will be the limit to make a trial with a cochlear implant in our practice. 4 years at the most. After that, you may lose CI and you may lose ABI as a second option. But I would like to just say a comment on Nilam. I absolutely agree. The understanding of the family on what's going on and the adjustment of expectations is crucial on all this fact. So maybe 3 or 4 years may be the limit, but depending on the family, this may not even be possible.
Yeah, sure. I think that's it. We have an upper limit to capture the neural plasticity even with an ABI. And I think once you cross 4 upper limit 5 years, then you've missed the boat. So that's the whole challenge. And then of course in our scenario where it's largely a self-pay situation, particularly for ABI and many places even CI, then there's a cost factors that we have. That's the additional challenge. So coming to what everybody's talked about, which is I think very, very critical, is in a situation like this, what should we counsel the family with regard to the outcomes in a cochlear implant? Because without a doubt, the long term, and I'm talking about, I would like to highlight long-term outcomes. Like Neelam has said, we've seen in the short term, not the aplastic, but hypoplastic nerve, where there is a reasonable nerve, in the first year, 18 months, maybe even 2 years, they seem to be progressing and not too far off from their peers or other cochlear implant peers. But as she's rightly said, and this is what we found in our experience, is that they will plateau. So what should we be telling the family in terms of the expected outcomes? Of course, they will fill the expected outcome questionnaire. We will match it with what we think. So what should we put down as to expected outcomes? Because there's a huge variability. We should be talking to them about the auditory outcomes. We should also be talking about the non-auditory outcomes, facial twitching and such like. What should we be telling them about the duration that's going to be required to achieve? Because when they walk into your cochlear implant clinic, lots of these parents are going to see children with cochlear implant who have normal anatomy, and they're going to compare their kid and expect that their kid is going to do as well or close to what the other kid is doing. And my next question is, what do we tell them about long-term outcomes and schooling in these situations? So who would like to very, very quickly take on that and answer that, please?
I think they will need special help in school. In the thing, they will be speech readers plus auditory. Most of them, though they have shown some who have done well, but they will need help, and they will actually perform like children with severe loss with hearing aids. Profound loss with hearing aids.
So what should
better?
What should we be putting down?
So we have to tell them that they'll need help in the school, and they may not get hearing skills as good as the other children. And the facial nerve twitch, depending on the way the scans are, I suppose we'll have to warn them, or even otherwise we'll have to warn them.
Well, I can
some might, yes, sorry.
No, go ahead, please.
And I think some might need sign also. They might have to have total communication, sign also, and this.
Okay, Javier, please.
Yes. What I was going to tell you is that how I manage this situation. When I have a normal child and a child with any other problem, I tell them that we have a large experience on cochlear implants. It's more than 30 years doing cochlear implant, so we know what happens. But the exceptions are exceptional. And I cannot tell them what's going on. I can tell them this is going to be difficult. I can tell them, as you said, I mean, you cannot compare with a child with a normal cochlear implant, just a congenital deafness. You can expect a very long time period of rehabilitation. And maybe you can have the idea you have to adjust your expectations to a plateau, not to a continuous improvement and being just like a normal child, as we are used to see in most cochlear implants. So exceptions must be treated individualized, and you must have a very good communication. That was what we were saying before. And it's not easy to, I tell them, I don't have a crystal ball. I cannot tell you what's going to happen. I can tell the normal child what's going to happen or what are the chances for this to happen. But with so few cases and such a short experience on ABI, and I always say, what I'm telling you is just the preliminary results of our ABAs. Maybe in 10 years, we come back and we find something completely different.
Okay. Anybody wants to add?
I think a lot of what they said was true. So the way I would tell them is the child will definitely do better than what the child is doing now. The child will definitely plateau. So you will see a good gain for some time, but then the child is going to plateau. I do tell them that just habilitation, we are going to need to introduce, as Madhuri said, total communication. So we start introducing signing much, much earlier in these cases. Instead, I would say it's right from the very beginning. And I specifically talk about schooling. Most parents come to you with the expectation that my child should go to a normal school. And this is what we need to specify to them, that they may get admission into a normal school, but sustainability in that school is going to be an issue. So the child usually will manage in the primary levels till about the second or the third grade, but then they start falling out. So you've got to tell them that right in the very beginning. You've got to stress on the fact that the child is going to need special attention in a school. So if you're looking at a mainstream school, you're going to look at a school that has the services of special aid teachers available. Otherwise, you are going to see a dropout. And somewhere you've got to talk to them about non-users, that there is a possibility that this child may reject the implant later on. So I think it sounds cruel, but it's something that you'd like to mention right at the outset.
It's realistic, and that's why it's important.
These children will definitely have a problem in mainstreaming, but at the same time, we should also tell them on the whole, their quality of life will be definitely better than if they are not implanted.
मेरा घर तो बंद पड़ा है, क्लिनिक में कौन होता है इस समय? दिक्कत ये तो है.
Dr. Monique Grover, you are not muted. If you want to mute yourself, please.
Did you get my point?
Yes, sir. Got it. So no, that's very valid. Now now we move on to the next recommendation. Is that, of course, these children had CI. We have covered the direct to ABI, so we've got the aplastic and all that. So we will look at ABI, and if they are below the age of 3, 4, or 5. Now, once these kids have been fitted with CI, this has been covered. And again, I think it's very important that we need to put in recommendations of how we monitor the progress. So, of course, we look at, like Dr. Gore said, we look at the auditory, the progress, we look at the aided assessment, the pattern perceptions, temporal perceptions, behavioral progress, speech and language. What about the use of EABRs to optimize the map or the EABRs to assess the progress? Dr. Gore, would it be appropriate that children with a hypoplastic nerve who've had a cochlear implant, see, while we are looking at the other parameters, which are largely behavior and speech and language, we know that that's going to take time. And like we've also talked about the fact that we have limited time. So we may have a subset where we at least have to talk to them about ABI maybe. So would, in this case, an EABR through the cochlear implant help A, in your map optimization, and B, in your decision making to move on? And it also means, what are the red flags? You mentioned that. So I would like you to just quickly highlight what would be the red flags in these children that we need to be aware of.
Okay, if they're getting facial nerve stimulation before they start hearing, or their thresholds are very high, and you're not getting an EABR. EABR is easy to do once the implant is, once a child is implanted, the artifacts are not so bad. So since it's an obligatory response, we should, that doesn't change so fast, but you get a pretty good response anyway as soon as the stimulation starts. So if you don't get EABR on certain, a large number of electrodes, or hardly any, then that's not a good sign. Sometimes we do get an ESR, that is very, very rare. And that's also worthwhile trying to optimize the map. But if we're not getting EABR and there are a lot of, there is facial stimulation and no percept of sound, then you have to move on.
Okay. Okay. So again, the question is, how long do we wait when we are doing? I think that has been answered already. That there is an upper limit. Either we stick, either the child will then stay with the CI and we accept the outcomes that they are, or then we make a decision whether moving on to ABI is actually going to add value to this child or the family, considering all the risks involved in this. So this comes to the penultimate thing, is that when we are in this situation, of course, we've looked at everybody's presented what the expected outcomes are. They will take time. We know that initially they will do apparently better. They will plateau probably at a cap of 5 or 4. Discrimination is not going to be necessarily very great. There's a lot of variability. But then the whole question is, will an ABI be? When do we decide that an ABI is going to be better, for this child? And then we say, okay, maybe the ABI is going to be better for this particular child, so let's refer you on to the ABI center if you are willing to have that. And therefore, how do we compare? I know it's a very loaded, heavy question. How do we compare the expected outcome of the ABI with what we're getting in the CI? And that comes back to you, Javier, because you have the ABI experience. So would you like to try and answer that?
Yes, well, the only thing that I can tell you is that results are variable and very unpredictable. You never know what's going to happen. We get hearing sensation in about 80% of the cases of our ABIs in children. It's a very good aid for lip reading in the case of no more result. And they can understand words without lip reading, I wouldn't say more than up to 20-25%. And of course, we can also find non-hearing sensation in a certain percentage of the patients that we have already mentioned. And this is not like with a cochlear implant that you disconnect one channel and nothing happens. If you have to disconnect one channel here, you start having problems. So this is what we have. We cannot do more. And if we move to this option, as you said before, if we stop seeing that this is not working at all with the CI and we move to an ABI, I think we can get improvement in the children performance. But these achievements will be very, very difficult to assess before you see what happens.
No, I agree. I would agree with that, because with our modest ABI experience, we've found the same. Some of them don't even get auditory percept, but they will get auditory percept, gross discrimination. A few of them will get some close set words, and that's about it. And of course, the whole issue is that it's only an aid to lip reading and sign, and we're very, very clear that they're just not going to get auditory-based language. That's out of the question completely. What was my, yeah, so this means that we've got to be very careful that when we are counseling our patients, even for potential ABI, that the results are very modest. So, but my question is going to be this. Now, there was some data from I think it was Levant and somebody else who suggested the sequential, in talking about sequential and simultaneous ABI, that the addition of an ABI to a child who's already got a cochlear implant seems to increase their score. I mean, our colleague, I think it was Dr. Saud's colleague from Egypt made that presentation. So what is your thought on that? So the child's not doing very well with a CI, but then you add an ABI and then suddenly the scores jump. Is that something that we should expect?
Well, I haven't done it. This is something that maybe we think about it and we can decide in the future, but right now I will go little by little.
Yeah, I think we have to be very, 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 very conservative. Okay. And finally, I'm not sure what the policy is in Spain or other places, because ABIs are, it's not simple, but you need the whole team, and the results are so modest and really very, very basic. Should we be looking at limited centers for ABI in any region or a country where the data can be collated so that we get more information, or should it be spread out? I don't know. What is the situation in Spain? And if I may ask Dr. Galal or Dr. Saad, what's the situation in Egypt with regard to ABI? We know the situation in India. Anything to say on that, please?
I mean, it's a very complex surgery. I don't think you can do one case every 10 years. So this must be limited to some research centers in the moment we are living now. But this is the same as it happened with cochlear implants at the beginning. And it's like that. I mean, you shouldn't put one cochlear implant here. You have to be in a center of cochlear implants, and you have to have experience on skull-base surgery. I mean, I am doing skull-base surgery for the last 40 years. So removal of acoustic tumors, vestibular neurectomies, all this surgery gives you the management of that area. Unless you have that, I think you cannot go on that, on this. And even if you have that, you have to have a very restricted programs until we see that this is the way to do. So every time I speak about this and I say, I think this is a good option and this may be an option, I just say this may be an option, but you have to be expert on the topic and doing selected centers.
Yeah, and of course you need a very good audiological team and habilitation team to manage them. Great. So can I conclude by, so we will put all this, we will put all this together, but I think the distill of this whole thing is that when we are looking at children with cochlear nerve deficiency or hypoplastic nerve, there are a few situations where an ABI may be the straight go-to option, provided the expectations are met and there's a family commitment, etc., and they know what to expect, like the significant nerve deficiency and absolutely no response on detailed audiological assessment, which is pivotal. But in most of the situations, would the panel agree to go with the recommendation that we should still consider a cochlear implant first? And in some you may get good response, in some it may be questionable, but it'll be a trial. We have to be very, very clear about the expectations and the commitment of the family, and all the other comorbidities that the child must not have or have limited off, so that they can get the best out of it. And the fact that the modality of language is going to be multimodality. It's likely to be lip reading, maybe gestures or sign, with some amount of audition. It may not be purely audition-based language. The results are variable, are unpredictable. The electrophysiology, like TTABR, cortical evoked responses, are there to support, but not sort of decisive, if you like, and the decision still is very much based on very, very good audiological and behavioral follow-up and management. And of course, it's as you said, you use the right word, the evolution, the hearing evolution or speech and language evolution of that child, is going to tell us the way to go. And of course, if they are young, then that's better, but that is not the real world, especially in our part of the world. ABIs, we tread with caution, select few centers, and very, very careful before we jump into that. Have I, in these 2 minutes, been able to sort of summarize what we've discussed in the last 2 hours?
Yeah.
You did great, Amit.
Okay. Anything? Because I'm done. But anything that the panelists want to sort of mention, so that I can make a note of it before we hand over back to Sunil, because he's waiting for us to finish. Dr. Panda, Dr. Rambabu, Neelam, Dr. Saad, Dr. Galal, Javier, of course. So anything that you think we should put in there?
I think you summarized very well what the main conclusions of our discussion this afternoon.
Great grasping, Amit. Great grasping. Good.
Great. So Madhuri, anything that You want to add? Because as I said, this whole thing is all pivoted on.
No, anyway, you say you did add the comorbid conditions, which is, I mean, and dysphagia and all those things which are.
Yeah, I'll take that from your, we look at.
It's, you already said that. So
yeah, we'll add that as well. Great. So Dr. Saad is still online. Anything you want to add, Dr. Saad? Or Dr. Gala?
Nothing. You are summarized very nice summary, and it was great discussion with you.
So I'll try and put that all together. So thank you very much for all your input and staying up for so long. It's been wonderful interacting with all of you. Thank you so much.
Thank you.
Thank you.
It was great. Yeah, great interaction.
Okay.
Great, thank you.
Thank you very much. Stay safe.
All right, hold on. Let me take it from there. And Amit, thanks a ton for a beautifully conducted World Cafe, the first of its kind here in India. And I think the inputs from all your panelists that we carefully selected, and I think, can I say confidently they were worthy of that selection we made. So I think the inputs have been absolutely fabulous. And if I may humbly summarize what transpired in the last 2.5 hours, I think better the radiology, better the audiology, including behavioral and electrophysiological, better the outcomes. I think that's a single line summary. When you're putting together, again, another humble suggestion, when you're putting together your summary for Sunday morning, try and see, and this is to all the World Cafe moderators, try and see if you can come up with recommendations that are that could be classified into desirable and essential. So essential criteria and desirable criteria, something like that. And that would help us put the paper together also later on for a reviewed publication. I would also like to thank the panelists. And please remember, you will get in the next couple of days a delegate platform link, which is for you for the whole conference, for all 3 days of the conference. In addition, if you have additional commitments in the various sessions, as most of you have, you will get a session Zoom link in which you would log in about 15 minutes like you did today prior to the session, and you would log out of that after the session and you can get back to your platform link. And that's the way this virtual conference is being conducted. Should you have any questions, you can ask me, email me, or message me on WhatsApp. Thank you very much once again, one and all, Amit, and all your panelists.
Thank you very much.
Thank you. Yeah.
Thank you.